rewarding surgery. So all these surgery, minimal invasive, the arthroscopic surgery, what is the advantage? The advantage is very minimal incision, very minimal soft tissue trauma. It leads to less postoperative pain, faster healing, and low infection rate. So these are the advantages of doing an arthroscopic surgery. Another common entity in elderly people is the frozen shoulder, adhesive capsulitis. So if we see routinely in our OPD, there are so many patients and they come to us and they say we have a frozen shoulder. So in a general public, in general practitioners, there is a common diagnosis that is a frozen shoulder, but not all the patients they are having the frozen shoulder. Frozen shoulder, we can say when there is no active or passive range of motion. So that is a frozen shoulder. If there is a movement, but there is still a pain, so diagnosis can be a different. It can be a rotator cuff tear, it can be something else, it can be a slap tear. There are so many things which can be there. So diagnosis has to be stamped. Frozen shoulder is usually affecting the elderly people around 45, diabetic and thyroid people, and they always have pain and stiffness around shoulder joint. Night pain is very worse. They cannot sleep on the affected side. But the good news about this frozen shoulder is that it is self-limiting. In few patients, it may last for 3 months. In some patients, maybe up to 1.5 years. But this is a self-limiting condition which lasts for 3 phases. First phase is phase of pain. Second stage, pain and stiffness, and third stage is the release phase. So insidiously, the patient is going to get better with the therapy. Essentially, the treatment is the physiotherapy. Most of these patients, I would say 98% of these patients do good with physiotherapy alone. In few patients, we may require steroid injections to relieve the pain, but it doesn't alter the natural history because ultimately patients need physiotherapy. But few patients, only 2% of the patient, they are refractory to all this treatment and they are painful, they are stiff, they cannot move, and they're affecting their lifestyle and they cannot sleep. So in those patients, we may require an arthroscopic surgery. Those 2% patient, here we can see the first image. This is the normal shoulder arthroscopic. There's no inflammation, there is no redness. But in the second image, this is the image of the frozen shoulder. So we can see the capsule is thick, capsule is red, inflamed, and there is no gap. The capsule is very tight. So we need to release this capsule, the glenohumeral ligaments, with an arthroscopic surgery. So I will explain this. This is the one case example. Not able to do forward flexion, abduction up to 90 degrees, severely painful. We did an arthroscopic release, and after 6 weeks of rehabilitation, she is able to do all the range of motion normally without any pain. Elderly patients, they might be having a rotator cuff dysfunction initially when there is a problem. So there are rotator cuff muscles. Those muscles stabilizes the shoulder joint and do the movement around the shoulder joint. So anteriorly there is a subscapularis muscle, posteriorly there is infraspinatus and teres minor muscle, and superiorly there is a supraspinatus muscle. That supraspinatus muscle leads to initiation of abduction, and the deltoid muscle is the counterpart of that. And subscapularis and the infraspinatus and teres minor, these are the force couples. So they act together in tandem. They act as a force couple. So any one of them is disturbed, it leads to a rotator cuff dysfunction. So rotator cuff dysfunction leads to superior migration of head, later on impingement. That impingement can lead to a rotator cuff tear. So this rotator cuff tears leads to weakness in the shoulder. They are having pain in their shoulder. That pain is quite worse at night, and it may radiate to the arm. They have their sleepless night. So in this picture, you can see the tendon of the supraspinatus. This is supraspinatus. This is subscapularis muscle. The tear is extending from supraspinatus to the subscapularis. This is one case example. So he's not able to forward flex the shoulder and also not able to abduct the shoulder and having a severe pain in the shoulder, and that is radiating to the arm. So this is the clinical scenario. We did the rotator cuff repair surgery. So arthroscopic, this is the arthroscopic image. Rotator cuff, this is the bone, the humerus side, and this cuff is torn from here. This is the footprint. So this was repaired with the anchor sutures here. And this is done with a few portals only. There are no scars, there is no long incisions. So this is done with these portals only. So this is the result after 3 months of rehabilitation. So the patient needs a continuous physiotherapy after surgery. So he is able to fully do all the movements, the forward flexion, the abduction, and he is pain free. So this is the result after 3 months. Another very common problem in elderly people is the shoulder arthritis. Shoulder arthritis we see very often in knee joint because we do squatting. A lot of Indian people, they do squatting, so that's why we often get knee arthritis. Hip and shoulder arthritis is quite uncommon in Indian population. Still, we see patients those are having osteoarthritis around the shoulder joint, and rheumatoid arthritis is also a common entity. There might be an arthritis that is following an injury, that is post-traumatic arthritis. But we need to differentiate between an osteoarthritis and a rotator tear arthropathy. That means that rotator cuff dysfunction is persistent and that has led to an arthritis in the acromiohumeral part and the glenohumeral part. So that is rotator cuff arthropathy. I will describe both of them. So this is how the primary arthritis, osteoarthritis, has the same process of aging that is there in the knee. But this rotator cuff arthropathy, this is a different mechanism because there are force couples inside the shoulder joint. That subscapularis muscle is coupling to the infraspinatus and teres minor, and this deltoid is coupling to the supraspinatus. So once there is a tear, there is a disturbance in this mechanism, and this leads to superior migration of the head. The head is abutting against the acromion. It leads to the acromiohumeral arthritis. Later on, it leads to the glenohumeral arthritis that starts in the superior portion. So this is not due to the primary arthritis that is due to aging. This is due to the rotator cuff dysfunction or rotator cuff tears. So what is the answer to these things? So in these patients with the arthritis or the rotator cuff arthropathy, we need a shoulder replacement surgery. So this is different in rotator cuff arthropathy and different in primary arthritis. There are 3 types of shoulder replacement, that is the hemi shoulder replacement, the total shoulder replacement, and the reverse shoulder replacement. So that I will take one by one. So for the primary arthritis, we need to do this conventional shoulder replacement. But if there is a rotator cuff arthropathy, then there is a deficient cuff. So all the function of the cuff has to be transferred to the deltoid muscle. So here, this is the humeral part, this is the head part, and this is the glenoid part. But in a reverse shoulder, the head is replaced with a ball here. This is the glenoid part. This is replaced with the ball, and the humeral head part, this is replaced with the socket. This is exactly the reverse of the normal. So in total shoulder, there is a replacement with the head, and here it is exactly the reverse. So this is one case example. This is a failed primary fixation of the shoulder. So here also there is no much bone left here, and this implant has failed and there was no infection. So we need to proceed with the implant that can transfer the rotator cuff functions to the deltoid muscle, because there is no tuberosities left out, so we cannot do a total shoulder here. That will be non-functional. So we did a reverse shoulder replacement. Here the socket is replaced with the head and head is replaced with the socket. So this is after the 3 month of physiotherapy after the reverse shoulder replacement surgery. So he's able to do forward flexion. This is the forward flexion. This is the abduction. So abduction is, this is bit less than the normal, but this is 120. That is quite normal. External rotation. So this is after 3 months of the surgery, reverse shoulder replacement. This is another case example. This is a 52 years old male. He has a road traffic accident. He was in ICU and he is a 2 times kidney transplant. So one time the kidney transplant has failed. Again, he received a kidney transplant. He was in ICU on ventilator due to uncontrolled renal functions. That went on for 10 days. After 10 days, we fixed the other trauma in the lower limb. We could not fix this fracture around the shoulder. This was quite complicated fracture, and this was fixed after 1 month to buy some time to get the patient better and recover from the ICU. So the humeral head appears to be shattered. In this X-ray, we could not appreciate the articular congruity, so we ordered a CT scan. This is the CT scan images, and the CT scan images shows that there is a comminution and the head is quite shattered, and there is also posterior dislocation. So this is the intraoperative images for that surgery, and here we could see that this humeral head is shattered. It is shattered into pieces. We did the hemiarthroplasty. We replaced the humeral head part only. We did not replace the glenoid part. So this is the result after 12 weeks. Able to do forward flexion, abduction, rotations. He's on continuous physiotherapy after that also. So his function are going to improve with time as well. So he's got good function after the hemi shoulder replacement. And another case example of shoulder replacement is the tumor around the shoulder joint. So this patient is having a CA esophagus. So he was operated for carcinoma of esophagus, and he got a solitary metastasis, and he's a good survival rate after that surgery, that is more than 2 years. So if this patient is not having a long-term survival, then we would not have done any surgery for this patient, but he is going to have a good survival. That's why we opted for a surgery around the shoulder, because he was having severe pain, not able to move the limb. So this patient was operated with a prosthesis around the shoulder, that is hemi shoulder replacement again. So this is an extended indication for the arthroplasty, the shoulder replacement around the shoulder joint. So these were different case scenarios with the results and different surgeries explained. From arthroscopic surgery to the open surgeries, the replacement surgeries, tumor surgeries, and also the fracture surgery. So these are so many advances in the shoulder surgeries in recent days. Previously, we used to almost hear that somebody has got knee replacement and hip replacement, but nowadays we are able to hear from someone that the shoulder replacement is also a common surgery, but it is not that much common related to knee joint, because these patients, the number of these patients are less, and another thing is the replacement is the cost constraint. This is a costly surgery. That's why we have these patients get operated less often. So I had this opportunity to being able to work with one of the best surgeons in the world. Those are the almost the designer surgeon of the few surgeries. The Algedo Hangudi, who designed the Oates procedure, the meniscus repair surgeon, or the Freddy Fu, he's almost the world's best ACL surgeon. So I had the opportunity to work with them and learn from them. This is my operation theater that is equipped with all the facility required for these high-end surgeries. This is my OT that is equipped with all the infrastructure that is required to do all these surgeries. And you cannot do all the things alone. So this is my team with the physiotherapist, the nursing staff, the support staff. So all these, they continuously help me to get the best result out of them. I was fortunate enough to get this diploma sports medicine with International Olympic Committee that was done in 2015, and it was the world's first batch. And also did my advanced team physician course for the sports medicine from International Olympic Committee that was done in 2016 at Morocco. And I had the opportunity to work with all the international athletes at Rio Olympic Games, and Deepa Karmakar, Sakshi Malik, and also I had these opportunities to do these surgeries of this national wrestler, national hockey player, national taekwondo player, and they also did well after the surgery. They had their skills, that's why they did best in there. But after the surgery, you know, to get the best result is quite difficult. But they did good after the surgery as well. He's Manish from national hockey player, and he's doing good. And here is another patient who is a national taekwondo player. He got an ACL surgery done 5 or 6 years back, and after the surgery he got this gold medal at the national games. Another patient, the posterior dislocation patient, he was back to sports. He's again a national level boxer. Another patient, he's a captain of the Air Force team. He got a revision ACL surgery done in 2016 or 17, I guess. And he's playing the best of his life after the surgery, and he scored the maximum in the last games. And he's not a national athlete, but he's a gymnast. He's also got the ACL surgery done 7 months back, and after the rehabilitation he's able to do gymnast at the local level. This was done at the village level. He doesn't have a professional training though. So in the end, I'm grateful to all of you for your kind listening, and also grateful that I've got all the opportunity to work with great people around the world. You can contact me by these links, website, blog, and there is a contact helpline number. So you can contact me by these things. Deeptam, I think my talk is over, and we can take any question and answer.
Thank you, sir. Thank you for such a nice presentation. You have highlighted the real life case scenarios, and I think it is very much helpful for the audience who have joined today. So we will be taking the Q&A, sir. So the question that we had is that have you faced with recurrent instability and neuropraxia?
I would say I have not seen such patients.